Ms. Eisen, thank you for coming.
Thank you for having me. My name is Vitka Eisen, and I would like to thank the committee for allowing me to share a provider's perspective. I represent HealthRIGHT 360. We're a family of programs that includes Haight-Ashbury Free Clinics, Walden House, and now most recently Asian American Recovery Services. We have over 20 different funding sources, from foundations to counties, states, and the federal government. We're also a federally qualified health center, and we follow some of the stringent requirements of HRSA and CMS. Our organization served over 49,000 clients last year with a combined budget of over $65 million, despite the fact that we're a rather large substance use disorder provider in California. Our total volume of Drug Medi-Cal revenue was $75,000, which is a little over 0.1% of our total revenue. This is due to the prior limitations on eligibility under the current Medi-Cal system. So while we have some knowledge of the system, we're not really a high-volume DMC provider at this time. However, in January 2014, that's going to change a great deal. And so we believe it's really important that we have these conversations now, because the lion's share of that 49,000 clients will probably become Medi-Cal eligible in 2014. We take our responsibility to operate with integrity very, very seriously for three big reasons. One, our clients are very slow to trust as a result of histories of trauma. So we work really hard to earn that trust and to keep it. And getting a reputation for ripping off taxpayers or anybody is a real trust buster. And maintaining that trust is really vital to being an effective provider. Two, I always say that as a nonprofit service provider, all we really have is our good name. We have to work very hard to protect it. And three, Medi-Cal fraud is a criminal act, and orange is not my new black. I don't really look good in orange, as I like to remind the staff, and neither does my board of directors. So we take this really seriously. And we have several things in place as a larger organization that we're able to do to protect our integrity and to protect our reputation. So we do weekly data, what we call clinical data integrity meetings. We literally meet weekly, a large team of staff, to kind of comb the data, make sure that what needed to be signed was signed, that whatever documentation is required was there, and when there's a break in the system, we try to fix it. We also check the Health and Human Services Office of Inspector General's exclusion list, which the feds maintain for excluded providers. We check all staff. And we have about now, I think, soon to be 650 staff. We check that staff against the list monthly, because we don't want to have excluded providers. We want to build Medi-Cal for an excluded provider. We have a whistleblower protection policy in place. It's part of our handbook. All of our new employees are trained on it, and there's an access to protect fraud and abuse. So I think, to echo what Al said, providers also have to take a great deal of responsibility to maintain an integrity of services. We have to do our part in that. So that being said, I also responded to some of the questions, and for the interest of time, Al and I agree on everything, so I'm not going to repeat the things that he said. I'll just add things where he might not have addressed or where we might disagree. In terms of burdensome requirements, there is some issues that we have with the current Drug Medi-Cal certification process. I think you're probably aware there's a Drug Medi-Cal state certification process, and separate from that is an alcohol and other drug program certification process, and they're separate, and sometimes they're overlapping, and one is required and one is voluntary, right? So the Drug Medi-Cal process can be burdensome. We're a drug medical provider in San Francisco. We've applied in another county. It's taken 19 months. And we're continually asked to resubmit documents that we've already submitted or to get lease modifications. And so the process is burdensome, and it doesn't, obviously, as we can see from the recent Center of Investigative Reporting, doesn't screen out fraudulent providers. If anything, it has served to screen out providers who have a 47-year history of delivering services with integrity. So I really think we should look at the process and combine those two and see which is the best of them, and try to streamline it a little bit, keep the best requirements in there. So in terms of what some of the effective programs of what was formerly ADP. I do think that the licensing and certification process for AOD programs was an effective program. They come in every other year. They check for health and safety. They review client files. They review staff certifications. I think that that's an effective program. I think the state maintains a very effective grievance program, and then they respond quickly to client grievances. Our clients have the ability to go directly to the state and file a grievance if they're complaining about our services, if they have a concern that's confidential, and the state responds quickly and thoroughly to that, and I think that that's a good process. And I think that the state maintains a uniform data system. Maintaining a uniform data system, it's called CalOMS, is now we may have some problems with CalOMS, but I think that it's important that the state maintain a uniform data set and that there's an evaluation standard within that you can evaluate programs. So we think that that conceptually is an effective program. I agree with Al regarding the physician sign-off. It's costly. And I don't think it produces actually a better outcome. I think having a specialist in the field of behavioral health might actually produce a better outcome and reduce costs. We have a concern with the one service per day. That's a requirement to a restriction under the Medi-Cal guidelines. You can only bill for one service a day. I think that's a barrier for our clients. If you have a client who has family responsibilities and they come to your organization for a service, and in fact they come and they get an individual counseling session and they attend 2 groups, you bill for one service. It's the same single service in a day. So if the organization wants to recoup some of its costs, you would then have to spread the service over multiple days. And that's not fair to the clients, and it's not fair to the organization that you're not able to collect the cost. So I'd like the state to relook at that if we have an opportunity to do that. The IMD exclusion, I think, is, again, I'm not going to go into it in great depth. I think it's an enormous barrier to care for low, and it's a parity issue for low-income people. People who are covered under the exchange and who have private health insurance will be able to access residential substance use disorder treatment. People on Medi-Cal will not because of the limit on the 16-bed programs. You had asked how we measure performance. Organizations such as ours, we typically have a number of metrics that we use. Client satisfaction is one of them. Improved quality of life. We're moving towards a standardized instrument for measuring quality of life, improvement in income, housing, family function. We collect client satisfaction on surveys 2 times a year. Our county collects client satisfaction independently of us annually. We also do focus groups with clients to get feedback on the program. And each program unit that we have has a client rep group that meets with staff, and they collect feedback on program and make modifications accordingly. We support the idea of moving the certification process to the counties. We agree that it should be a state standard, but that the process works currently with our short dole programs. The counties certify it, and that process seems to work. As Al said, there are certainly difficulties accessing some of the effective evidence-based programs, but they're out there, and there are websites that are great resources for programs to access them. And NREP, the federal SAMHSA, has a website, and you can find tons of nationally recognized effective programs. And there was a question regarding should there be a criminal background check to be a Drug Medi-Cal provider, and I would say no. Ex-offenders have been an integral part of the substance use disorder system of care. I would prefer to see an enhanced ongoing monitoring and training program as an effective means for preventing fraud and abuse. We have many folks who are ex-offenders who have been providers in our system for quite a long time, and they provide service with integrity. And finally, should requirements for registered or certified counselors be increased? We would recommend that the counselor requirements should be unified and moved under something like the Board of Behavioral Sciences. Currently, multiple organizations certify, and they have different requirements, and we would prefer to see it moved under similar to licensed clinical social workers or the Board of Psychology. Thank you for letting me speak.
Thank you. Dr. Pan.
Well, I want to thank both of our providers for testifying. One of the things that that's probably more of a statement than a question is that Well, first of all, I appreciate that there are going to be some recommendations to the department regarding recommendations around certification. We'd be very interested in seeing those, as well as the department's working on the certification process and ensuring that we reduce fraud. I think one of the issues on the medical director, beyond just who can do it, is that again, what is the the department's proposing that we be sure that they're all enrolled in Medi-Cal, to be sure that whoever's doing that role is doing it responsibly and is acting ethically. I really wanted to comment, though, is that I think one of the things we want to be sure is that as we're pursuing the fraud, that sometimes the response to a wrongdoing is to actually turn to the people actually delivering the service and say, here, we're going to put some more requirements on you because that, versus saying that, well, what does the information really need to root out fraud? And we're also and if we ask that of you, we promise we will be looking at that, not just that, well, here's some more forms to fill out, now we've taken care of it, yet that's still sitting on the shelf like all the other information that you might have been filling out before, to be sure that whatever is asked of you is something that's going to be useful to investigate, to identifying fraud, and someone's actually constantly looking at it, that we minimize the burden on the providers, because I know I think, again, apropos to what Ms. Snella said, is that most people are acting appropriately, and also, most importantly, these are vital services that are needed. Shutting down providers who and access to these services is not what we want to result from what happens today.
Thank you, Dr. Pan. Does any members of the committee have any questions of this panel? Seeing none, I just have a couple, and we've talked about this in earlier panels, but since you're the professionals out in the arena providing the service, who provides the training, and if it's are you seeing delays when you request it, if it's provided to you?
From my end, I'm aware that there has been a TA contract that the state has had with a private entity to do training. I have not personally accessed that. I am aware that it can take quite some time because it's a very small TA contract. I've heard this feedback over the years. We do a lot of our own internal training, but that's limited in terms of resources as well. The counties, some counties put on trainings, and we try to take advantage of those as they come about. But there's a lot of room for more training. There's a big need.
Like to segue on that?
Yeah, typically, we either provide training, our county has provided training, and then some provider associations, because we're a federally qualified health center, and they're all over fraud, very concerned about fraud and abuse as well. CPCA, for example, will provide it, which is a statewide agency of community health centers.
Thank you very much. And so what would DHCS and counties do better to prevent possible fraud in the provider community, in your opinions?
So I think training is incredibly helpful, and I think I really appreciated the county panel's thoughtfulness about how often things may be perceived as fraud were actually errors. And so I think that really an ongoing training process, particularly at the county level, is incredibly helpful where that occurs. Because again, a lot of what we see is mistakes. They weren't intentional. Staff need to learn better how to chart and document, and so county training support would be great.
So, sloppy record keeping isn't fraud, but sloppy record keeping goes on much more than it should, and more training would help reduce that and reduce some of the headache and problems for everybody. On the fraud side of things, I can tell you I'm a large organization as well, and Vitka probably gets visited by as many monitors as I do, if not more. Almost every other week I have somebody in auditing one program or another. But in all the years that I have undergone various audits, from whether it's the state, whether it's the county, whether it's the city, whether it's the federal government, the audits that I underwent as part of this whole Drug Medi-Cal issue were very sophisticated. They knew what they were doing, and they knew how to go about looking for whether or not fraud existed. So I don't think I'm an expert to advise them on what else they could be doing to do it right. These particular teams that came out as part of the DHSC audits were up to speed.
Well, thank you very much, and it's always a great experience when we have people that have skin in the game, the professionals that come up and engage and help us through this process. We've talked to the state, we've talked to the county, and we've also have providers, and I really do appreciate you taking the time and providing your perspective on how we can do things better in the state. And I look forward to your engagement with this health committee also, so that the process can be brought forward and help our friends in the DHSC to provide that balance. But again, I want to thank you so much for